Turns out, C. difficile's unexpected aftermath. Your gut survived the infection. Your gut won, actually. The antibiotics nuked the bacteria, your body recovered, and everything went back to normal. Except it didn't. Months later, you're still running to the bathroom, still bloated, still miserable. And here's the thing, it's not the infection coming back. Your body is basically broken in a new way, and almost nobody saw it coming. What if the real damage from some infections isn't the initial hit, but what they leave behind? This is the question that's been nagging at researchers for years. We know that after certain infections, food poisoning, traveler's diarrhea, even the stomach flu, some people develop this weird ghost version of the illness. Persistent symptoms. No active infection detectable. The bacteria are gone, but the body remembers in all the wrong ways. Scientists call it postinfectious functional bowel disorder, which is a fancy way of saying your gut works like it's broken, even though technically it's not. The assumption was always that Clostridioides difficile, that notorious hospital-acquired infection, was different. Get treated, clear the bacteria, problem solved. But a new study from the University of Virginia just threw a wrench into that assumption. And what they found might change how we think about infection recovery entirely. The research team behind this was led by GP Wright and a crew of infectious disease specialists at UVA's Division of Infectious Diseases and International Health. Their collaborators included gastroenterologists and epidemiologists, the kind of interdisciplinary dream team you need when you're trying to track something that lives in the grey zone between infection and gut dysfunction. They published this in July of 2026 in Open Forum Infectious Diseases. This wasn't a quick 3-month study. They spent 3 years tracking what happened to C. difficile patients after treatment. And what they were about to discover would force the field to completely rethink who actually gets better and who just looks like they did. So here's what they actually did. They went into their complicated C. difficile clinic, yes, that's a real specialized clinic at UVA, and pulled the medical records of 159 patients who came in between March 2020 and January 2023. These weren't healthy people experimenting with infection. These were people who had gotten slammed by C. difficile, and something had gone wrong enough that they needed specialized care. The team didn't just count infections. They dug into everything: age, gender, medical history, mental health records, what medications people were on, comorbidities, all of it. Then they divided patients into groups. One group had straightforward recurrent C. difficile, the bacteria coming back, documented and confirmed. Another group showed up with the same symptoms, but the bacteria weren't actually there. Those people had what looked like infection, but was actually functional bowel disorder. Think of it like showing up to the emergency room with all the symptoms of a car accident, except the car never hit you. The damage is real. The pain is real. But you have to figure out where it actually came from. The numbers tell a wild story. Out of those 159 patients, 44, that's 27.7% of people who came in thinking they had a C. difficile relapse, actually had functional bowel disorder instead. More than a quarter. That's not a rounding error. That's a whole subgroup of people getting misdiagnosed, or at least misunderstood. 90 patients had actual recurrent C. difficile. 25 patients had initial infection symptoms. Then there was this 44-person group where the infection was gone, but the body was still waging war on itself. Here's where it gets interesting. The two groups weren't the same kind of people. Patients with CDI-associated functional bowel disorder were younger on average. They were more likely to be female. They had fewer underlying health conditions. In other words, they were the people who should have bounced back easiest. They weren't chronically sick. They weren't immunocompromised. But then the researchers found something sharper. People in the functional bowel disorder group had way higher rates of anxiety and depression. The statistical significance was massive. P less than 0.001 for anxiety. P equals 0.003 for depression. That's not just statistically significant. That's genuinely striking. When they ran the numbers again, controlling for other factors, the fewer comorbidities piece stuck around. But the mental health piece, anxiety and depression, kept shouting louder in the data. And here's the most sobering part. At 3 months after diagnosis, patients with functional bowel disorder were actually doing worse. They were less frequently rated as well by clinical standards. They weren't recovering on the same timeline. They weren't bouncing back the way the straightforward infection group was. The body had learned to be sick in a new way, and the psychiatric history seemed to be part of the story. So what does this actually mean for someone dealing with this? If you get hit by C. difficile and you recover from the infection, but months later you're still symptomatic, this study suggests several things. First, your doctor might not be looking for what's actually wrong with you. If they just see persistent diarrhea, they might assume the bacteria came back when it actually didn't. That leads to overtreatment with antibiotics and probiotics that might not help. Second, and this is crucial, your mental health history matters more than we thought. This doesn't mean the symptoms are in your head. It means your nervous system's baseline, whether you run anxious or depressed, might influence how your gut responds to trauma, including bacterial trauma. The functional bowel disorder is real. The pain is real. The symptoms are real. But the source might not be what anyone was looking for. Now, the honest limitations. This was a retrospective study, which means they were looking backward at medical records. They weren't randomly assigning people to get infected for research purposes. That means some details got lost. They also weren't comparing these patients to a healthy control group, so we don't know if the anxiety and depression rates are actually elevated or if they're just normal baseline rates. The sample size was small, 159 people in one clinic at one hospital. So this raises a question more than it answers it definitively, but it raises a really important one. This study cracks open something the medical field hasn't fully reckoned with. Not all post-infection syndrome is actually infection. Some of it is how your body learns to stay sick. Some of it is the nervous system getting rewired. And some of it might be that infections trigger something in people who already have a predisposition toward anxiety or depression. The gut-brain connection isn't poetry, it's neurobiology. Your enteric nervous system has more neurons than your spinal cord. Stress and anxiety literally change how your gut processes and responds to stimuli. What if a severe infection in someone who's already anxious doesn't just cause temporary diarrhea, but actually sets that relationship on fire in a way that takes months to cool down? That's the implication hiding in these numbers. The bigger picture is that we might be treating the wrong problem. We've built entire clinical protocols around killing bacteria and testing for cures. But if a meaningful chunk of post-C. difficile symptoms is actually functional disorder rooted in nervous system sensitization and psychiatric history, then antibiotics aren't going to touch it. Maybe what these patients actually need is a totally different approach. Gut-directed therapy, cognitive behavioral therapy, maybe even psychiatry consultation at the same time as gastroenterology. This study suggests that the real crisis isn't the initial infection. It's what your body remembers after the bacteria are gone. The single most jaw-dropping takeaway is this. Recovering from infection isn't just about clearing the pathogen. Recovery is about what your nervous system learns in the process. And if you're wired toward anxiety or depression, that learning might stick around long after the threat is dead. So here's the question worth sitting with. How many of your chronic health problems aren't actually about your body being broken, but about your nervous system learning to stay afraid? Turns out, scientists have been busy, and they're not done yet.